We are here with Dr. Julia Aronoff, who's going to answer all sorts of mostly asked questions about advanced detox. And I'm asking her to dumb down her answers so that somebody like me can understand. So, Dr. Aronoff, can you start by giving us your credentials?
Okay. I have a degree in medicine, which I got in New Jersey almost 30 years ago. I finished residency in anesthesiology in the University of Michigan. I got board certified in anesthesiology in 2001, and I got a board certification in addiction medicine in a few years before.
Okay, perfect. You've been doing the opiate reversal procedure for how many years?
I have been doing it since early 2008.
Wow, okay. And there's been some talk that here at Advanced Detox that every patient gets the same treatment. So tell me about your approach. It isn't one size fits all, is it?
I don't believe in medicine anything is one size fits all, especially in such complex situation as anesthesiology and addiction medicine. Every patient is different, every person is different, and has to be approached in an individual way.
Perfect. You help people get off Suboxone, methadone, kratom, all opiates, all opioids, fentanyl, and tramadol, and each one of those treatment plans is different?
They do differ somewhat, but I also adjust them as the treatment goes on, because we don't know how a patient's going to react to certain medications, or what kind of, everything has to be adjusted according to their vital signs, according to the way their body is reacting to my treatment.
Perfect. So the process is individualized per patient.
Absolutely.
Okay. One of the questions we get asked are whether we do IV sedation or whether we do anesthesia where you intubate the patients. Do you believe it's necessary, like some places do, to intubate the patients?
Absolutely not.
Why?
I have been doing this for a long time, and yes, I know that when this procedure was created in the early 90s, it was done under general anesthesia with intubation, very invasive, and the deeper the level of anesthesia needed, the higher the risk. That's bottom line. And you don't want to swat a fly with a hammer. Anesthesia has to be tailored to the amount of painful stimuli that patient has. And so, even though precipitated withdrawals are very uncomfortable and very painful, all we need to do for those is IV sedation. We do not intubate, we do not do anything invasive. Not that I'm not able to do it, I've been doing general anesthesia for almost 30 years, but it is not, absolutely not necessary.
So what you're saying is you don't need that level of intervention in order to do this procedure.
Absolutely not. I think it just adds to the amount of risk that patient undergoes.
Perfect. And our patients are under sedation between 8 and 16 hours, you'd say. And at that time, you're doing that so that they get through
the hardest part of the withdrawals. What we do is we precipitate withdrawals by replacing the opiate or opioid at the receptor level with a blocker. That's what pushes the body into withdrawals.
Perfect. Now, why did you decide to open a private hospital where the patients can stay for 4 full days versus other places that put patients in a hotel after the procedure?
Well, I used to work for a clinic that used to do that. I was incredibly uncomfortable doing that. I felt that the patients are not getting the level of care they need. especially the day right after the precipitated withdrawals took place. Um, I pulled away from that practice and opened my own in 2017, and from then on, my strong belief is that all of this has to be done under medical supervision from the beginning till the time we discharge.
And I always look at it like most of us who work here are mothers, and
Yes, I have 5 children and multiple grandchildren, and I try to treat, or I do treat each and every patient as if they could be my child, and that is how important their outcome in their life is to me.
yes. Now, one of the last things I am wondering is there's some places that do opiate reversal that talk about fine-tuning or modulating your brain during the procedure. What exactly does that mean versus what you do, which is resetting the receptors how you do it? Explain the difference to anyone listening.
I think the talk about modulating, fine-tuning,
I mean, is there a switch that you...
there is no switch, and that is why societies like Addiction Society of American Society of Addiction Medicine does not take this kind of claims seriously, because there is no magic, there is no fine-tuning. What we do is we work on receptor level to precipitate withdrawals, we address symptoms, and we make it as humane as possible.
Okay. And in regard to making it as humane as possible, the claims that people have that this is easy, painless magic trick. Anyone who tells you you'll have no symptoms after any medical procedure, including this one, is not being truthful.
Absolutely. And I don't believe in lying to my patients. But this procedure is stressful. The body will feel it, even though they might not remember it, and they will feel the post effects, what's called post-acute withdrawal syndrome, which is your body healing itself, and
So,
that takes time.
Right, and when the body's healing itself and there are symptoms, do you have medications that you write for these patients to address that?
Thankfully, the medicine of addiction has improved by far in the last few years. There are new medications, there are new ways to address pretty much every symptoms you might have. Not all of them work 100%, but they mitigate the symptoms as much as possible.
Perfect. Well, I really appreciate you answering all of these questions. I'm sure it gives people some understanding, and I appreciate your time. Thank you so much.
Anytime.